Sure, I would just like to thank you for joining us for September 2025 Grand Rounds. And a quick reminder before we begin that this session is being recorded and an AI generated summary will be produced and shared afterwards. And we can also enable closed captions on the bar below if that's helpful. Today, we are joined by our Global Offsite Care Medical Director, Dr. Pecchia, who will be introducing our speaker, Dr. Gill.
Great. Thank you, Katie. And yeah, I think enabling the captions probably a good idea, given our international audience. And also thank you for the introduction. I'm Dr. Gregory Pecchia, Medical Director now for the past 4 years of Global Offsite Care and the Global Ground Rounds, and also am a director in the Division of Academic Innovation and Telehealth at Western University of Health Sciences in the greater Los Angeles area of California, specifically in Pomona, as well as one of our campuses also, which is up in north of California in Oregon, in Lebanon, Oregon, and Central Oregon. With that, I'd like to again introduce one of our serial speakers. Thank you again, Dr. Gill, for your past presentations, and a little bit about him having completed medical school in Pakistan and his internal medicine residency in New York at the NYU Grossman School of Medicine in Brooklyn. He's been practicing medicine for over 15 years, currently transitioning into primary care practice. Welcome to that, Dr. Gill. And he is board certified in internal medicine and obesity medicine, and is doing a fellowship in addiction medicine at UCI. I assume UC Irvine, but you can clarify that for us. Is that right?
Yeah, that's it.
Wonderful. Okay. He's practicing a hybrid model that integrates internal medicine and addiction medicine. In this presentation, he explores the challenges of addressing substance use disorders in underserved communities where limited resources, stigma, and systemic barriers often prevent individuals from receiving adequate care. By recognizing addiction as a chronic disease, he highlights the need for integrated continuous treatment and examines practical solutions such as telemedicine, mobile clinics, culturally tailored programs, and policy reforms that can improve access, equity, and outcomes for those most affected. So again, thank you for joining us today. Dr. Gill, the floor is yours.
Hi, good morning, everyone. Thank you, Dr. Pecchia. Thank you so much for the good words, and I'm honored to be here discussing such an important topic. Please let me know if everyone can hear me or not. I'm not very tech savvy. I can fix the volume. I like doing lectures with some engagement from the audience. If we do have a way of asking questions, please go ahead. And in the middle of presentation too, I will allow you to interrupt me if a topic that you would like me to clarify. So we are going to just quickly go over how can we approach substance use disorder in underserved areas. And I made this slide targeting the United States, but I did the general presentation. So if outside the United States, where we're facing a challenge, not very good support in the field of addiction medicine, you can hopefully be able to benefit from some of it. The objectives we know Dr. Pecchia already mentioned. So let's jump onto the case. And this is one of the prime example I see. This is a real case. This was 3 weeks ago when I was making the presentation. And this highlights some of the issues, and actually a major issue and many levels, what we are facing with. And so a 22-year-old Hispanic male, he presented to the clinic. He was terrified looking, anxious, and was not able to sit, flushed, and clear withdrawals. And he also wanted to change. So that was fortunate that he actually walked in and wanted to get help. On further interviewing, the patient reported that he has been using multiple substances to feel better. One substance, withdrawal of that substance, to counter those withdrawal effect, he will pick up another one. And to counter intoxication and withdrawal, he will pick up the third and the fourth. And the cycle goes on. And usually this is the typical case for most of the patients. Once the addiction disease hits, it is a compulsive and impulsive phenomenon. And that leads to multiple polysubstance use, we call it, and eventually overdose. Mariposa County is one of those counties of central United States where there aren't many services available. The provider to patient ratio is not great. We just researched, fortunately, and came to our clinic. So this patient actually had a very significant history of substance use disorder with his parents having the disease, growing up in that environment, and went to foster care for obvious reason. Then currently living in a situation where girlfriend was also using substances. They had unplanned pregnancy. The CPS got involved. They took the baby away. What motivated him was that it has been 6 months that he has seen his infant. So you can imagine the suffering a 22-year-old person can be in. And this is one of the profile and example that how much we need to understand this disease and how much help we need, not only in the United States, but throughout the world where this is happening. I wanted to add one point here is, which also puzzle a lot of clinicians. How do I tackle this patient? Nurse practitioners, the PAs, the first line of defense of our medical care. It makes us a little uncomfortable. What am I going to do with this patient, right? Today, we're not going to learn the whole addiction medicine subject, but at least some points where that you can start. What I want you to remember today is that when you see a patient coming up with such mixed symptoms of intoxication as well as withdrawal, please determine what is he using in a very non-judgmental and compassionate way. And that does not take too long. And if you have the opportunity to engage with the patient, prefer to start treatment for opioid withdrawal or opioid use, unless patient is visibly shaking and is unstable vitals-wise or hallucinating, which means that most likely it's benzodiazepine or alcohol withdrawal, and you send the patient to a facility for management. But the opioid use disorder take the priority in taking first step. The underserved areas in the United States, we consider rural communities, urban underserved areas, and frontier areas of native reservations. The rural communities of the United States have scarce provision of specialists. And those are the communities which comprise of the small towns in part of frontier areas or the native reservations. Very few physicians are available. If there's still herbal medicine being practiced, then obviously they don't know what the disease of addiction is. And the urban underserved areas where I practice, it is a big town. It's actually a big city. However, the outskirts of that city, we still have not many providers. And the providers that we have do not have a full scope of practice. Their clinics are not set up the way that they catch or screen patients with addiction or screen and take the intervention to prevent fatal overdose, which has become epidemic in the United States. All these areas have very high prevalence of alcohol use disorder, opioid use disorder. Native reservations had highest death toll due to COVID-19 pandemic. It was very significant if we look at the data. So all these important points may and direct us towards the need of understanding how much we have to focus on deliverance in this part of the United States. So what is actually causing a little bit of obstruction? I would say major reason that addiction medicine is not perceived as important as other fields of medicine because of the aberrant nature of the addiction, how it establishes. For past 4 decades, we have put tremendous research into trying to understand what this disease is, the processes. Sorry, this is a little bit of cramped slide, but it is a very good slide if you want to save it and look at it after the lecture. As you know that it starts somewhere, right? The research data over and over showed that at least 50%, which is the average, at least 40% to 60% of the time, it is the genetic component. More than half of the reason that someone will have addiction to a substance is their genetic makeup, their genotype, and then epigenetics that come into play later in the life. So the first step in the development of addiction is what we call digitoxication, that the person takes the substance, the reward phenomena get activated. It is a connection between the tegmental area and the ventral area of midbrain. Those neurons, they end up in the nucleus accumbens of our mesolimbic system. The nucleus accumbens has the core of that thalamus. The thalamic nuclei has the most innervation for dopamine neurons beside the other neurotransmitters like glutamate, norepinephrine, and serotonin, but the dopamine is the dominant one, and it is involved in reinforcement, positive reinforcement, and the development of a learning experience that this substance had created pleasure. So that pleasure is coded right away deep into our memory, which is hippocampus, right? And the dorsal nuclei, and the amygdala, which are keeping the watch that don't let this go. And when this pleasure fades, they get activated, create negative emotions, telling the brain, get more. And this is a brain phenomenon. And if we look into our lives, we go through this all the time. This morning, I would give an example that I picked up the cup of coffee. That is my addiction, right? And although I do have a physical dependence on it, there is some psychological dependence. That's what caffeine does. Now, the problem happens. Now, this was out of my control. But what happens is how I go from here. I have learned this behavior in my frontal cortex, which is orbitofrontal cortex, that has the processing of reinforcement, reward, and inhibition as well, which is in the lateral part of the orbitofrontal cortex. The medial part processes the reward. A few hours after, when I be seeing patients, my reward phenomena will get a hint from the amygdala and the hippocampus, which is the memory, and they both combine and tell me, hey, you need to get a little bit more stimulation that will feel good, and you'll be able to have more gentle and fun conversation with your patient. So my frontal cortex will process that, and that is where the voluntary action happens. Now, with addiction of the substances that are harmful, the same thing happens. However, they affect our cognition. Coffee is not proven to cause problems with the cognition, problems with the aberrant behavior, problems with obsessive compulsive nature, that it takes away my inhibition. What I'm trying to establish here is that the phenomena exist there. Now, some people are more prone compared to other, depends on genetic factors when they're born with. And there are tons of genetic alleles that we have learned that their mutation have created their dendritic neurons synapse in such a way that one substance creates such a huge influx of dopamine that the person gets such high pleasure reward that it lightens up the whole mesolimbic system and the frontal cortex, ending up high negative withdrawal when that substance is not available. So what I'm trying to establish here is that this is a neuroadaptation, and these are the different factors, the neurocircuits, the synaptic systems, the molecules at the level of neuron synapses and epigenetics. Quickly, it is a factor where come into play. For example, person has a genetic predisposition to develop stimulant use disorder. However, it is dependent on a multiple episodes of stress. So if that stress doesn't come into play, that might not get activated. But if that person is going through PTSD, for example, or the soldiers on the combat field, those epigenetic factors come into play. And now those addiction genes get activated and that person gets exposed to that substance, it will immediately be hooked. This is called epigenetics. I want to establish that this is a disease. It is a chronic disease based on a chronic disease model, just like any other medical disease. This is the slide that will tell us about chronic disease model. And if you look at the data, there are 7% Americans have a diagnosis of cardiac disease, okay? And 13% have some form of cardiac disease. So let's just have this knowledge in the background. Now, let's think of the addiction dependence on a substance based on the molecular phenomena we just learned. 10% Americans more than 12 years old have alcohol use disorder. Okay. Only 40% of them are seeking some help. 17% of those of Americans have some kind of substance use disorder. So you can see the prevalence, how much prevalent it is, and how many are seeking treatment, and how many even know that they have substance use disorder. And while we are putting these numbers out there, they're based on the criteria that DSM-5, the Diagnostic and Statistical Manual of the mental health and substance use criteria. And out of those, 17%, 19 million have with cannabis use disorder, 6 million with opioids, and 1.6 million with stimulant use disorder, methamphetamine 1.8, cocaine. It cost us $600 billion annually. And this cost come from visits to the ER, hospitals, and repetitive visits. If one of you has had a chance to work in the emergency room, you know how many times one person comes there. And I was hospitalized, and at the time of, I would say, the ignorance, when I didn't know about this disease, I would say, oh my God, this person again, he has already come to the ER 3 times. What I failed to understand, that this person is trying to get help. He is suffering from a disease that he has no control over. He's suffering from a disease that has taken effect, just like coronary artery disease, just like hypertension. If they get the treatment, they will get better. If they don't, this continue to get worse. And just like someone goes into hypertensive crisis, that person will go into intoxication and eventually withdrawal or overdose and die. So this is the most important slide I wanted to say for today's, if you want to take the message. This is where the most difference can be made. Wherever you are in any part of the world, you can make that difference. A patient usually walks into a primary care clinic or a general practitioner or GP, different names in different part of the world. That is who see that person the first time. Statistically in the United States, more than 50% of the people who has committed suicide saw their primary care physician the last visit they had with their doctor. They did not go to a psychiatrist. They did not go to a surgeon. They did not see a gynecologist. Hey, I feel bad and help me. They went to the primary care physician, and the primary care physician didn't have time to screen that person for suicide, and that the person who's suffering has no idea how to express himself. He's just depressed. He went there to help. It was the opportunity we missed at that time to screen them, and they end up committing suicide. Apply the same thing here. Lots of patients when they come see the first line of the gatekeepers, we have opportunity to screen for substance use disorder and catch them before it goes to fatal overdose. The data also shows patients who had non-fatal overdose, they are going to have a fatal overdose if not caught. Okay. So few things, just quickly mention PHQ-9 or PHQ-2. This is the patient health questionnaire. This is to screen for depression or depressive disorder, or someone is not doing well in their life. Or you can just ask one question, and that comprised most of it. Hey, how's life? How are you doing at home? Are you doing well? That question can open up a door. Or generalized anxiety disorder. These are few screening questionnaire. They're available online. You can download. The Columbia Suicide Severity Risk Scale only had 3 questions, but these questions are very vital and they can have someone open up. And this is a mood disorder questionnaire. Again, you can get them. Fortunately, we live in such a small world now. Everything is connected, and all these surveys are available. Right now, the tool that we are using is called SBIRT, Screen, Brief, Intervention, Referral, and Treatment, SBIRT. We call it SBIRT. This was developed to catch chronic diseases before they get worse, like patients. For example, someone has cancer, right? Patient will not tell you, hey, I have a stage 2 cancer. It's our job. And when we get trained, go through medical school and training, we have been developed such reflexes, like treating colon cancer immediately without thinking. We go into investigating and staging. We got to do same thing for addiction. Like I said, we want to prevent fatal overdose, and that is the time when we screen and find out that actually that person is using substance and actually using pretty harmful way. At that time, if you do the intervention, you have a highest chance to save their life, bring them back to the community, and make them a beneficial part of the community. And as we know that this is hitting our younger population, and it does not discriminate, the level of education does not discriminate the profession. There might be some demographic differences, but they're not huge. The gap is closing. Everyone out there on the street has a risk of developing substance use disorder if not educated or not caught in time. Alcohol use disorder, only one liner has been developed after studies and studied, that you can simply ask, how many times have you had 5 drinks or more, one sitting in 1 year? And if they tell you yes, 1 or 2 or 3 times, that's it. You grab that thread, because this person is at highest risk for developing the disease and going into a pattern of obsessive and compulsive nature. Cage, when I was in med school a long time ago, we were told about this question. The not able to cut down, annoying, guilt, and eye opener. We all know that. I'm sure we do. Again, all available online. Audit C is the most lengthy one. The cage is a good screening. This one-line question, if you can do that. If you don't have time for audit, which is alcohol use disorder identification test, if you don't want to do that to go into the depth and what's going on, you can just ask cage 4 questions. If not, you can ask 1 question. Same thing goes for the drugs, other drugs, the opioid use disorder, the stimulant use disorder. I want to quickly name what are these drugs are in context of our audience, or might not have the same names for the drugs. The alcohol is the most prevalent throughout the world, as well as cannabis. We all know that. Opioids in different forms are picking up all over the world, and that includes fentanyl, carfentanil, isofentanil, many names. The fentanyl that poachers use to take down elephants. We have patients coming in using carfentanil. Just a micrograms of drug has caused overdose on the first-time users, because that fentanyl is used to bring down elephants. Please make sure that what are the drugs out there in current day and age. These are different screening questions. We'll go over quickly what the challenges are, but which are inhibiting us to get this out in the field, help our patients who are in need and are not aware. There is a shortage of addiction specialists, many primary care providers. If they are providing services in underserved areas, they have lack of knowledge, or they have the knowledge, but our system is not in such shape that they can provide good support. The geographical isolation, one problem that's throughout the world, I'm sure. Wherever you live, if you look around, you will find those areas where you do not have the care. How can you counter those challenges? Telemedicine, this platform, it can be vital. And it is vital. Technology has perks, and this is one of the best ones. During COVID-19, we have made huge difference. The medication-assisted treatment prescribing, I was doing the telemedicine services for addiction for the past 2.5 years. And we were talking to patients living in towns over mountains, and they were not able to come down, travel 2.5 hours. And we were so proud to provide service for them. Then mobile treatments. There are street medicine vans actually do services in Bakersfield in Central California, San Francisco, and same thing can be established in other counties. Then some loan repayment and financial support that the federal government is actually doing this, incentivizing the groups. There are a few barriers to it. The stigma is one of them. Waivers we used to require, the FDA has taken the 8-hour waiver away. Now anyone who will want to get a DEA license, they will have to have this training. So that is a good thing. And now NPs and PAs can prescribe buprenorphine, which is a treatment for opioid use disorder. Stigma happens because we don't understand the disease as a chronic disease. And there are reasons to it, because this disease involves behavioral problems. This disease involves cognitive issues. Person with the hypertension, when the blood pressure goes up, goes hypertensive crisis because he's not taking his medication. The statistically evident that the non-compliance of diabetes is equal to non-compliance of substance use disorder. They equate. However, we don't have a stigma against diabetes because it does not have cognitive deficits. They do some level, but it is not considered a moral problem. The diabetic is not going and stealing because their compulsiveness of the disease is not that strong. So these are some elements that is unfortunately the part of the disease processes that push away from taking any action and helping those people. And so we think that he just has to toughen it out. Why is he not having the willpower? Why is he's morally so weak? So that stigma has prevented many people to get help. Harm reduction concept is lacking. We'll talk about it next. So there are many solutions to it. PTSS is a Michigan University initiative. You can go to the website, open up many lectures, and share with your colleagues, learn yourself. ECHO is one of the programs that I think UTSF is administering. So it's online learning for free, PCS for free. There are many changes made to methadone take home now. It's much more easier to take home from methadone. You don't have to go every day. So if someone is wanting to get into methadone treatment, please let your patients know that it's so much easier now to get into methadone treatment program. After 2 weeks of sobriety, you are able to get 7 days take home. So you only have to go 14 days to the clinic and you will get 7 days of supply. So you will not have to go every day. After 14 days of sobriety, you will go every 7 days. And after 31 days of sobriety, you will go after every 28 days. So it has made such easy for opioid use disorder now as far as methadone comes. These are some social determinants: the poverty, the unemployment, the childcare. Many patients, they're not coming for treatment because they don't have availability of daycare. The housing, the food insecurity where we work. So you can get many social services involved. The primary care physicians have this opportunity to investigate, have their staff investigate and coordinate. And hand out pamphlets, information to your patients that it's out there. There are food banks, there are social counties at their county level can do some programs. You can integrate services, the medical services integrated as mental health services, the mental health and substance use disorder. I think I forgot to put that data in it, but I think the last data, if I'm correct in remembering, about 16 million people are suffering from severe mental illness, and almost 8 million of them are suffering from substance use disorder. So the severe mental illness has such high association with substance use disorder, and you can catch in screening, and then you can have integrate care. So it's not episodic, it's more parallel. Like we just talked about, it's the judgmental attitude, usually in small towns, and that is because of the exposure and reminders. The isolated providers, they don't have that kind of access to new data, new updates. Fortunately, with this time and age, they can do that. And so these are some of the points that I come up with while I was searching for answers. Harm reduction concept is the second most important message for today. Is after understanding the screening for first liners, please understand that the concept of harm reduction is not to promote or enabling someone to use. However, it is understanding the person's psychology develops when someone gets stuck in the chronic relapsing disease of addiction. It only allows the patient to feel and have some control. In chronic disease of addiction is perceived by the patient as complete lack of control, which leads to the stress response, and that stress response make that person go into constant episodes of panic and obsessive compulsive attitude, where the same time they are trying to feel better, they are wanting to be part of the society. When I was early in the fellowship, I asked one of my attending, I would like to share this with you. I asked, how about these patients who lack these understanding of these values of society, or who don't want to be those solid people out there working, have strong values. And so then he showed me some evidence that everyone in the society, doesn't matter, coming out of prison or living in isolated area or has a lack of education, has this need to, number one, be productive, number two, be part of the functional society. So it's just a matter of how we approach and how we motivate or bring that motivation they already have, but don't have a way of bringing it out. So what I'm trying to say is that when you see a person coming into the clinic, whether they know they have the disease of addiction or not, or if you discover, or if they're coming for help, they all have this need to get better, all of them. And it just matters how do we approach them. And harm reduction is one of that way of exploring and providing help. It is the autonomy that patient will have some sense of control. It is a goal of that patient based on their knowledge of health. And once you are able to have a parallel approach, they will be able to open up to you. Then you can walk them through and get them to full abstinence. And the second part of that harm reduction approach is to minimize complication associated with those substances, like overdose. And what are the examples that you can achieve these goals, having them take back control, follow their health goals, minimize complication, syringe services program, so you can minimize or stop the HIV and hepatitis C. Thank you, Katie, for the reminder. These are some of the steps. The Narcan is free now. You don't have to have prescription. Providing test strips for fentanyl, which is the reason of overdose, and some of these services if you can provide the injection facilities. I will go quickly now, some of these boring, rather, slides for most of us. And these are some financial insurance barriers that physicians come across, and this is something we have difficulty with. Fragmented services, if you look around wherever you're practicing, and I will quickly name these different parts of our society. Prisons, people in prison, they have certain services. When they come out of prison, suddenly they don't have insurance. They don't know how to get a job. The families are not too friendly to them. So that it's a huge population. Then other mental health related facilities that do not have integrated support with the medical care. Workforce limitation, we already gone over it. The solution is, again, you don't have to have physical presence in the area. And one of the biggest solution is telemedicine. This is something not all of us are keen, but something we must know that we are part of these. We can be a part of those communities who make policies or part of the regulatory processes. Or at least we can send our feedback through a medical association, through California Medical Association. So we do have those facilities and opportunities, and we must utilize them. Currently, there is a across the aisle approach fortunately in the administration at the government level to decriminalizing and not have such harsh punishment for possessing substances. And because the research show that it brings down the criminal behavior and has brought less delivery of drugs when the law enforcement and the judicial system was appropriately managed and is less harsh on patients or people possessing substances. I'm really trying to be careful mentioning that, but that is a very important point. The key takeaways are we understand what disease addiction is, a chronic disease, and we have not very good services. Underserved area do include some urban areas. The gatekeepers, primary care providers can make a difference, and they are the frontliners. And if they can catch at the level of first exposure patient has, integrated care, clinics, residential cares, sober livings, prisons, hospitals, medication-assisted treatment hub. If we do integrate, that is where the difference will be. Currently, we are lacking that integration of care. This is something we have a huge opportunity for improvement. Then stigma, providing help, recovery supports, expand coverage, and equity-focused integrated approach. So with this is the last slide. Thank you for having me. I'm really honored that I'm able to speak about this. Any questions, please?
Thank you, Dr. Gill. That was an excellent review and really practical for those of us in primary care, in particular, the frontliners, as you say, which would be ambulatory care clinics, general practitioners, if you will, who typically are over-enrolled and under-resourced when it comes to screening and treatment for this type of a condition, as well as urgent care settings, emergency room settings, where many folks who are suffering this way from this condition often will, as you well know, and in a place that maybe isn't the best for them to be identified, initially treated, and then eventually managed to a better day ahead for them. My single question is, if I'm back in the clinic, let's say after this lecture and later today, if I were in the clinic and as luck would have it, my first patient ends up being a patient who is reaching out for help, and I'm fortunate enough to screen that patient and find that they fall into this category. Wherever I may be, especially if I look up my schedule and there's 30 or 40 more people ahead to be seen during the day, and I'm already an hour late to the office because of maybe a morning meeting, something like that. What might be an option for me as a caring, concerned general practitioner to be able to get this patient at this really critical moment for them where they need to be, whether it be in a brick and mortar clinic with resources, expertise, and training necessary to take great care of them, or whether it be in the virtual space, online, via telemedicine. What would be a dependable resource that I or my staff could access at that moment?
That's exactly what, thank you for asking this question. And that is the biggest challenge right now we have, Dr. Pecchia. And what you can do is very few things. I will make a list of 3 items. Number 1 item is to have resources from around your community. Know where there is a medication assisted treatment hub available. Fortunately, we do have in almost all counties, these services at the county level. There is a government initiative, the state level, the federal level initiatives are present. The Contra Costa County, the San Francisco County, the San Mateo County, they all have mobile services. So there are resources. So let's get to know them. Have pamphlets. If you ask them, they will drop pamphlets for you. You just have to go online, ask for help. They will drop information, hand it over. Hey, this is where you're going to need to call. Ideas of harm reduction, needle exchange. Provide them those pamphlets. You don't need to ask them, hey, do you use injection drug use? But provide them information that when they look, they will find, oh, I need that. So that's something we all can do. And second point, knowing to approach. That's why I asked when someone comes, the first slide was that someone comes with multiple drug use problems. You are able to screen and identify what would you do. Now, in order to obtain DEA license, you have to have 8 hours of training. So by default, now going forward, all the providers should be able to give out buprenorphine. Right now, if someone agrees to methadone, for example, it's true, you have only 5 minutes to 10 minutes, right? But once you screen for less than 5 minutes, that's 2 or 3 minutes. Now you determine that the priority comes to their substance use and mental health. So you can quickly screen them for mental health. Are you depressed? Are you suicidal? If they are not, you can right there can offer them buprenorphine, methadone, and tell them, hey, come back. And as a regular provider, surgeon, gynecologist, primary care, you can do 3 days of methadone treatment without having any federal OTP license right now until you get someone to methadone program. Buprenorphine, you can do office-based treatment. Buprenorphine, you can do face-to-face telemedicine treatment. It's the awareness and a little bit more knowledge, unfortunately, that I don't want to say that I want you to learn more, but what I'm saying is that we can bring more services and it does not take that long.
Great. Yeah, thank you. And getting right down to the issue of, I think in the experience of many GPs, they have maybe one opportunity to act on maybe the identified patient who's suffering from this disorder. And if they miss that opportunity, they may never get that chance again. And so, thank you for sharing that with us. We're up against the end of the hour. If there are any other questions, we can take one more, and I'll keep an eye on raised hands or anything in the chat. And I've got some nice comments from some of our attendees. Thank you for that. Hearing none, again, I want to thank you so much, Dr. Gill. As always, it's a tremendous presentation and opportunity to talk over this important topic. And with that, I will hand it back to Katie to close our session.
Thank you, everyone. Thank you so much. I'll get back to my clip. Katie?
Thank you, Dr. Gill, for your very insightful presentation. We are coming towards the end of our time here. Just a reminder that this recording will be uploaded to our YouTube channel in a couple of days. And as always, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again.